So welcome everyone to the first of the Sunday Conversations with Mass, ME, CFS, and FM Association. Physical occupational therapy for ME, CFS, and similar chronic illnesses. My name is Carrie Lang, and I am the guest moderator for this program. I am an expressive art therapist and the Wellness and Mental Health Program Manager at the Dean Center for Tick-Borne Illness at Spalding Rehabilitation Hospital in Boston, Massachusetts, where I also lead support groups for long COVID patients. Our featured speaker is Kenneth Friedman, Ph.D., Adjunct Associate Professor of Medicine, School of Osteopathic Medicine of Rowan University, Stratford, New Jersey. Dr. Friedman has contributed to 3 nationally recognized primers on ME, CFS. He's written numerous articles about the disease in peer-reviewed journals, participated in the U.S. Department of Health's Chronic Fatigue Syndrome Advisory Committee, and he's edited 3 medical journal issues focused on ME, CFS. Our 2 discussants will add their perspectives to Dr. Friedman's presentation. They are Alba Azola, MD, Assistant Professor and Co-Director of the PMR Post-Acute COVID-19 Team, JH PACT Program, Department of Physical Medicine and Rehabilitation, Johns Hopkins University School of Medicine, and Amy Mooney, MS, OTRL, an occupational therapist who is also the mom of a severely ill teenage daughter who has had ME for 7 years. Dr. Friedman, take it away.
Thank you. Again, I would like to reiterate that the opinions that I am about to put forward are my own. And I would also like to thank the Mass ME, CFS, and FM Association for this opportunity. I think it's a marvelous way to promote discussion, and hopefully the discussion that is within the group can also migrate outside the group in terms of providing awareness and education to others who may be unfamiliar with ME, CFS, and what I consider to be similar chronic illnesses. So in order to begin the discussion, I thought that we would need to know where the history of the illness has been and where we are now. And so I thought that we would start with a group of questions as to where we have been and where we are as of 2022. So the first question is, what is ME/CFS as of 2022? For those of you who may have been in or aware of ME/CFS in the past, you probably know that there are multiple case definitions of ME/CFS. The reason there are multiple case definitions is that none of them have really been satisfactory. The case definition that seems to be the most popular now is that which has been proposed by the Institute of Medicine in 2015. And that definition relies heavily on something called post-exertional malaise. And post-exertional malaise is defined as the worsening of symptoms subsequent to major or minor physical or mental activity, with the symptoms of worsening appearing 12 to 48 hours after the activity and lasting disproportionately long, namely for days or weeks after the activity has been performed. This slide is just to indicate that the Institute of Medicine criteria or case definition for ME/CFS has been adopted by the CDC. And as you can see, the first criterion is that there is a substantial reduction in the ability to engage in activities, whether they be occupational, educational, social, or personal activity. The second criterion is that post-exertional malaise has to be exhibited, and the third criterion is unrefreshing sleep. And these first 3 criteria are mandatory. If one of these 3 is missing, then by definition, under the IOM criteria, you do not have ME/CFS. And then A fourth criterion has to be available, but there is a choice of which could be the fourth criterion, either cognitive impairment or orthostatic intolerance. In my experience, both are usually present, but to satisfy these criteria, only one of those two need to be present. I should also like to say that the IOM criteria was really designed to be for clinicians and clinical diagnosis, although now it is also used for research purposes. And that has always been a problem, namely that there have been two sets of criteria, one for clinical use, one for research use, but that has been largely been ignored, and there has been overlap, which confounds the literature and makes it very difficult to appreciate what truly is ME/CFS. One of the things that is not in the literature that confounds ME/CFS is that there is a large range of debility exhibited by ME/CFS patients. Starting at the bottom of the slide, it goes from mild to very severe under the third bullet of the slide. That range, or the range of severity, is astonishingly not in the medical literature. Rather, the severity scale was published by the ME Association of the UK. The ME Association of the UK is under the leadership of Charles Shepherd, who is, I would say, one of the premier ME/CFS experts. So I am certainly willing to accept his criteria. Under those criteria, and this is my summarizing in very few words what those criteria would be. Mild would be able to care for oneself and able to work part-time. Moderate severity would be unable to work and would require help or some help with personal care. Severe would be a patient who is housebound, and very severe is a patient who would be bedridden. And unfortunately, the medical community is not terribly aware of the severity range, so that when a physician who treats ME/CFS is told about bedridden patients, that physician may say, well, that person clearly doesn't have ME/CFS, but that patient does meet the criteria. So there is essentially division among ME/CFS care providers as to what truly is ME/CFS, which is one of the problems that I think we need to recognize. The other point that I would like to make is whether or not ME/CFS is a unique illness. From the early 1930s, when ME/CFS was first described by the United States Public Health Service, until I would say the 21st century, ME/CFS has been considered a unique illness, and people have been looking for the unique cause of ME/CFS. Although people like me who read some of the literature and realized that there were cases of ME/CFS that were caused by other than one particular virus, and people were still looking for a unique virus, realized that maybe ME/CFS had more than one cause. But with the onset of COVID, and particularly the onset of long-haul COVID, it became particularly apparent that ME/CFS really doesn't have one cause, and maybe rather than being a disease unto itself with one cause, rather it is the response to a kind of infection. So we have one study of COVID-19 in patients who had developed, 1/3 of those patients have developed what is termed long-haul COVID. And as has been demonstrated most recently by Wang and Weitzer in 2021, who did a meta-analysis of long-haul COVID patients, specifically looking for overlap between long-haul COVID patients and ME/CFS. They were able to conclude that using meta-analysis that there is overlap between ME/CFS and long-haul COVID. As an aside, I would like to say that the way this paper came about is that Danielle Weitzer, was an applicant to the New Jersey Medical School Medical Student Scholarship, and that's a medical student, medical resident scholarship program when she applied. She was not successful the first year, but under the rules of the scholarship program, if you are not successful, you may reapply. Only people who are awarded are barred from getting a second scholarship. So after she was a winner her subsequent year of applying, Danielle asked if there was anything more she could do to assist the community, and I suggested that this meta-analysis would be most appropriate, and she enlisted the aid of her mentor, Dr. Wang, and the two of them went and did this meta-analysis. And of the papers that are in this particular themed issue of dedicated to ME/CFS, the Wang and Weitzer paper is the most accessed paper in the entire issue of that journal. So let's go on and see what Wang and Weitzer discovered. Out of the 29 listed symptoms for ME/CFS, all but 4 were reported in at least one of the long-haul COVID studies that were acceptable in their study. All 3 of the major ME/CFS criteria symptoms, which were fatigue, as we have seen in the IOM criteria, reduced daily activity, and post-exertional malaise, were reported in multiple studies of long-haul COVID, and that fatigue was reported in 12 of the 21 studies, making it the most frequently cited symptom of long-haul COVID found in common with ME/CFS. So it's not post-exertional malaise in this particular case. It is fatigue that is the most common symptom in common. One thing that I would like to argue as to the similarity between ME/CFS and long-haul COVID is the relationship of onset of both diseases being very similar. I was kind of tickled by Anthony Fauci, who probably you are aware is the White House COVID-19 response team's chief medical advisor, said during a White House briefing that many of you are now aware of what had been called long haul or long COVID, but is actually a post-acute sequelae of SARS-CoV-2 infection, which we are now referring to as PASC, i.e. post-acute sequelae of SARS-CoV. The reason it tickles me is because about a week or two earlier, our paper had been published that had proposed a very similar category of disease in which PASC would be one of the constituting illnesses. But for this particular point, the point is that the onset of PASC, or long-haul COVID, is very similar to the onset of ME/CFS in many patients. Namely, there is an acute infection and a number of the patients who have this acute infection simply do not get better. So is this unique for the 2 illnesses, ME/CFS and long-haul COVID? In my opinion, and again, this is my opinion, I'm going to say no. I'm going to say that there are post-infectious viral and bacterial illnesses or syndromes that have been recognized for at least 50 years that have lingering symptoms. And so we have proposed this term PAPIS, which means post-active phase of infectious illness syndromes. And we published this in an issue of Medicina, which is one of the themed issues that I have been a guest co-editor of. And the references here and the references will be posted. They're the last 3 slides of this presentation, so you will be able to find it. So what is the difference between PAPIS and a category that has been in the literature? I'm going to say it's been a very fuzzy category in the literature known as post-viral syndromes. And there's a typo here. This should be in brackets PVS N bracket, not PVSO. And the PVS stands for post-viral syndrome. So the differences are, at least as I'm conceiving PAPIS, is that PAPIS is more inclusive. In other words, the onset of a PAPIS syndrome or illness can be triggered by a viral, a parasitic, or bacterial infection. And the second difference is that for PAPIS, as I conceived it, has to have overlap of symptoms with both ME/CFS and long-haul COVID. For my version of the PAPIS proposal, I would like to say that regardless of the trigger or the original source of infection, each symptom of a PAPIS illness will have a similar underlying pathophysiology. By training, I am a physiologist. I have worked on species from invertebrates through humans, and what I find is that there is a commonality of mechanisms, so that commonality of mechanisms, if they go awry, the way that they go awry is probably going to be similar. And so therefore, the commonality of the pathophysiologies most likely can be ameliorated by similar treatments. And so the caution that I would like, or the advice that I would like to give to healthcare providers, is that they need to be knowledgeable about the treatments which have been successful for one or some of the PAPIS illnesses, and to take a chance that a similar symptom exhibited in some other PAPIS illness will likely be treatable by a treatment that has been successful for some other PAPIS. I thought I would put in a slide that dealt with the impact of long-haul COVID on healthcare, because it is a potentially devastating illness with devastating impacts on healthcare. A systematic review of 57 studies comprising more than 250,000 survivors of COVID-19 found that more than half of these COVID survivors experienced long-haul COVID or PASC symptoms extending 6 months after recovery. And most common among those symptoms were functional mobility impairments, pulmonary abnormalities, and mental health disorders, which would severely impact their ability to function and severely stress our long-term healthcare ability to respond, to provide treatment to these patients. And so this is what we may be facing. And so the sooner we start researching and the sooner we start providing treatments for these patients, the much better off we will be as a nation as a whole. This no longer is a small problem. This is a very large problem. And as we can see with Omicron, that a very large problem impacts the entire functioning of our society. So having this problem, well, one question we can ask is who treats ME/CFS and who treats long-haul COVID now? Unfortunately, or I will say in my opinion, unfortunately, there seems to be now a division of labor. We have healthcare providers who treat ME/CFS and other providers who are willing to treat long-haul COVID. So for ME/CFS, we have relatively few physicians. If you look at the ME/CFS US Clinical Coalition, you find only 22 members listed. And you will find that if you look at the last patient satisfaction survey that I could find, ME/CFS indicate that they are currently an underserved population. Whereas if you look at the treatment that long-haul COVID patients are getting, as of August 3, 2021, 44 long-haul COVID clinics have been launched. It is unclear to me whether they would be willing to see ME/CFS patients, or for that matter, other patients who have other PAPIS illnesses. And so it seems to me that at some point and somewhere in our healthcare structure, we need to develop a strategy which will be overcoming the increasing healthcare worker shortage and be able to provide healthcare to all these PAPAS patients as a group. So under these circumstances, I would say that we need to mobilize all of our healthcare practitioners, including physical therapists and occupational therapists, which is the subject of this particular discussion. In my experience, physical therapists are concerned with restoring bodily function, whereas occupational therapists are tasked with restoring the abilities to perform needed tasks. I think both are needed, and in actuality, I think what happens is that the divisions between the two are blended. I think that physical therapists sometimes give advice or help with occupational therapy tasks and vice versa. And the example that I would like to provide to strengthen my point or my argument is the example of Stacy Stevens and the Workwell Foundation, which hopefully some of you are aware of. Stacy and I both started serving together on the Chronic Fatigue Syndrome Advisory Committee in 2003, and we have remained in touch ever since. But Stacy has been the one who has discovered that ME/CFS patients need to stay below their anaerobic threshold. And she has demonstrated this by using a technique that she developed called cardiopulmonary exercise testing, or CPET. And I would classify that as being part of her physical therapy mission or physical therapist mission. But she has also been advocating to patients to divide their tasks into blocks so that they do not work for long periods of time, and intersperse those blocks of their task with intervals of rest. And I would argue that that is in the domain of an occupational therapist, so that the two dovetail with each other, and it's hard to really separate one from another in a particular patient. So I was uncomfortable giving this presentation because I really had not been following the literature of the contributions of physical therapy and occupational therapy to ME/CFS. So I asked Amy Mooney to conduct a PubMed literature search. She actually conducted several of them, for which I thank her. I did look it over, and in my opinion, based upon my background and my experience with medical literature, my conclusion is that there are few quality physical therapy and occupational therapy studies of ME/CFS. There is a fairly recent study in 2021 which reaches the conclusion similar to mine, that there is no scientific evidence when it comes to effective physiotherapy for ME patients. And of course, my wife jumped all over me. What does that mean, no physical scientific evidence? So I decided that I would insert an interpretation of what I think is meant by that statement, which is that the data that is in the literature for physiotherapy does not demonstrate a statistically significant improvement of physiotherapy for ME/CFS patients. There is also an online survey, or the results of an online survey of ME/CFS patients has been studied for rehabilitation, which has found both positive and negative experiences of rehabilitation for ME/CFS patients. So therefore, the term that I would use is that the online survey of ME/CFS patients for outcomes of rehabilitation is equivocal. Among the positives that were cited for rehabilitation is that the patients found that the communication is supportive of their situation. The benefits of a routine linked with a baseline setting and pacing was found to be beneficial for them. The value of setting of a goal was found to be beneficial, and it gave them increased confidence in their ability to do at least some exercise. The negatives associated with rehabilitation, for some, obviously not the same as those who found benefit, was that they found poor communication, and the juxtaposition of support communication with poor communication means that the relationship of the patient to the therapist is extremely important. And I would say that if you do not have a good therapist or one with which you have a good relationship, then it's time to find another. Among the other negatives is that they feel that they were being pushed to exercise beyond a sustainable level, which some of you may know is a no-no. You do not do that. You do not go beyond your sustainable level. Another negative was that they felt that there was no plan that if they suffered a negative effect of their physical therapy or their therapy program, that they had a way of recovering, that there was no specific way of getting back to where they were prior to overdoing. And that should they fail to improve in their therapy program, that they were being blamed for the failure rather than it just being something that happened. So at this point, at least from my perspective, being outside of both fields, but being an observer of the field of ME/CFS, I would say that there is no data thus far that proves the benefit, no protocols that prove the benefit of physical and occupational therapy. I think that both patient and healthcare provider, regardless of what the status of that healthcare provider is, should be aware of how at least some healthcare providers feel. And this was published again in a themed issue, and this is the response of Tony Komaroff, who some of you may know. And this is the response of Tony Komaroff to the first ever publication of a description of what it's like to be a very severely ill ME/CFS patient. Whitney Defoe, who is a very severely ill ME/CFS patient, was encouraged by me to tell his story, and I would endeavor to get it published, which we were able to do. And then based upon that content, I felt that it needed to have some response from the healthcare provider or the physician community. And so I asked Tony, who is rather articulate, to write a response, and he agreed to do that. And so I extracted his paper, which is reference 16 in this slide set. And this is what I think Tony said, the major points, that when standard laboratory tests of a healthcare provider of his or her patient come back normal, and you cannot make a diagnosis based upon that. And so you have four choices. You can order more specific tests. You can say, I don't know, I really can't help you. You can provide treatment based on the symptoms themselves without any confidence that it's going to help, but just try and help the symptoms. Or, which has been true for a majority of patients who have ME/CFS, the healthcare provider concludes that there's nothing wrong with this patient and dismiss the patient, which is the worst for the patient in terms of healthcare. With regard to dismissing the patient, I think that is becoming less frequent now because there is a large literature that suggests that there are abnormalities in 5 areas. Namely, there are abnormalities in the brain, the immune system, abnormalities in energy metabolism, abnormalities in the autonomic nervous system, and abnormalities in the gastrointestinal microbiome. So the lesson for healthcare providers that I think is the most primary basic lesson to be learned is that one simply does not dismiss a patient's symptoms because you cannot explain them. It's either you accept them as symptoms without knowing what the cause is, or you delve further into what those symptoms are. So for guiding principles for healthcare providers, which I believe include occupational and physical therapists, I would say that the guidance that we provided in our IACFSME, the International Association for Chronic Fatigue Syndromes, adult primer is appropriate. And I've attempted to extract them here, which is to educate your patient to minimize his post-exertional malaise by pacing his or her activities. In other words, not exceed their energy envelope or delve into their anaerobic energy metabolism. Propose small amounts of work between periods of rest. And even though that may be difficult for the patient to do, please emphasize that it may be possible to accomplish more by working in small spurts interspersed with periods of rest than by working in a continuous fashion for a longer period of time. Advocate for the use of activity monitoring devices such as activity logs or more modern versions like heart rate monitors and step counters in an effort to get the patient to understand the relationship between his or her activities and their energy limits. It is the patient, him or herself, who is the only one who can control his or her amount of effort. And when the patient becomes experienced in knowing when they are reaching their energy limit and thereby being able to stop, they will be more successful in managing their illness without succumbing to post-exertional malaise. As a healthcare provider, and I think this is particularly true for therapists, because therapists, I think, spend more time with their patients than physicians do. You can be part of the chain that identify the pre-existing comorbid conditions that a patient may have. And either you can treat them or request that the patient relay them to the appropriate healthcare provider, because by treating the appropriate comorbidity, the overall health of the patient will ensue. As a healthcare provider, ask which symptom is the most troublesome or most bothersome and try and treat that first, because by treating that which is most bothersome to the patient, you give that patient a sense of accomplishment and the overall outlook of the patient will improve, and therefore the overall health of the patient will also improve. ME/CFS patients have reported acupuncture, chiropractic, Pilates, and massage have been helpful. You can try them. There's no specific treatment that works for all patients. Please remember that. And for evaluating a patient and develop a treatment plan, the DePaul symptom questionnaire is useful. Both patient and providers should treat each other with respect. That is the basis for a good, healthy relationship. Confrontation, anger, and accusations will rarely improve your healthcare. If you're not getting the respect that you deserve as a patient, you need to move on to some other healthcare provider. There are an estimated 2 to 2.5 million ME/CFS patients, and there are approximately 146 million COVID patients, and an unknown number of them will come up with long-haul COVID. And there are very few PTOT improvement studies for ME/CFS patients. So what needs to be done is that we believe that these kinds of illnesses should be under the category of PAPIS, or post-active phase infectious syndromes, and that we need to generate a list of projects that would be helpful, that they can be articulated in journal articles, and that we can develop mechanisms for collection and reporting results, and that manuscripts can be written that will be helpful to all these patients. Here's the deal, as our president would say, is that we have a journal now that has a topical collection, which means that articles can be submitted and published as they are written, and eventually they will be bound into a collection. And that if you do write or are instrumental in having written an article about PT and OT manuscripts that are helpful to any of the PAPAS illnesses, we will be happy to consider it. And now we will move on. Thank you.
I think I get to speak now.
Dr. Right, Dr.
Yeah.
Azola, please take the floor.
Yeah, my name is Dr. Azola, and I am a physiatrist, physical medicine and rehabilitation physician. And I have the pleasure today to share about my experience learned as I stumbled into the world of ME. Early in the pandemic, our pulmonary colleagues asked the rehabilitation division to collaborate in creating a long COVID clinic to address patients that were going to have rehabilitative needs. And I wasn't quite sure what was going to be like, but I agreed. And I've learned the importance of our role in this type of clinic and in the care of patients with long COVID. And to be transparent, in our long COVID clinic, we treat patients that have lingering symptoms after acute COVID that may have been severe, that may have been an ECMO or in ventilatory support. But we also treat patients that were infected and weathered it at home. And I started to learn about, by listening to my patients, to learn about what they were experiencing. And I knew that I didn't learn about this in medical school, and I wasn't very familiar with it, but I quickly started to look for areas of knowledge. And I knew a little bit about POTS because we have a good POTS program and autonomic dysfunction, but I have been on a quest of learning and understanding ME and how I can be a best help for my patients. So I just wanted to share as a perspective as a physiatrist and the role that I think physiatry serves to this population of patients. So in physiatry, we focus on identifying health conditions and environmental factors that are resulting in an impairment of a patient. That is kind of the concept of rehabilitation medicine. So we focus our treatment on enhancing functioning and participation in life. We identify and treat health-related impairments. We assess what the limitations are and try to find environmental ways to decrease limitations to activity and enhancing the environment to allow patients to be more active and have the ability to have a fulfilling life. So that's our biggest why in physiatry. And I think that this really goes along with chronic illnesses related to post-infection. So lessons that I learned, listening to your patients and validating what their patient is experiencing goes a very long way. And that's how I learned about ME, just listening for an hour to what my patients were reporting to me. And I made mistakes along the way. We knew that exercise, and there were some protocols for exercise that were really helpful in patients with autonomic dysfunction. And we had a group of physical therapists that were highly trained in helping with these exercise protocols, improve physiologic measures that optimize function in patients with autonomic dysfunction, in particular those with postural orthostatic tachycardia syndrome. But quickly we realized that exercise is not always medicine. And I know I'm preaching to the choir here, but it was how we started to understand what was really happening and started to expand our knowledge on this type of illnesses. So listening to your body it's a very big key. And that's something that I believe in as a physiatrist, that our body's smarter than our brain. So, I always encourage my patients to connect with their body, pay attention to the signals, and know that that is going to be the best guidance. So that's been something that I've learned, helping patients come to acceptance, to really understand their body signals that are sensations, and how to improve their ability to do the things that they really want to do by keeping themselves within that window of energy that they can function in. So implementation of compensatory strategies and non-pharmacologic treatments are very important. And these are the basics. There are some medication and pharmacological interventions that we can utilize to improve orthostatic intolerance, to improve certain pains that people are experiencing or discomfort on either GI symptoms. So there's many things that we can symptom manage depending on what's important to the patient, neuropathies, for example. But compensatory strategies and non-pharmacological treatments are key, and getting the patients to buy into that is super important. Energy conservation strategies are everything, and I concentrate on my visits with my patients on talking about pacing, planning, prioritizing, and positioning, and how that applies to their particular lifestyle. If they're a young mom with kids, what is that going to look like? If they're, they have to do laundry or they're caretakers for somebody else, it's all of those things. How can we personalize those energy conservation strategies to them? And that's where our therapists have found a place as well in terms of the therapeutic approach to patients suffering from lingering symptoms of COVID that manifest with post-exertional malaise. And multidisciplinary patient care is key, being able to coordinate between the medical team, the multiple specialists, therapists, listening to, the therapists definitely spend more time than us, like Dr. Friedman mentioned, with the patients, having meetings, multidisciplinary meetings to communicate with them, hear feedback from what their sessions and what the patients are going through is super important. And then the rehabilitation psychologist, at least in our multidisciplinary group, has been incredible. This rehabilitation psychologist specializes on helping patients deal with new impairments and the changes that causes in life. So rehabilitation psychologists, I think, are a key component, and even social work in assisting our patients obtain the benefits that they so badly need. And that's all I wanted to share in terms of the physiatrist view, the role of our care on patients with chronic illnesses after infections, in particular, my personal experience with long COVID. And I think Amy is going to join us next to chat a little bit about her experience as an occupational therapist.
So thank you, Dr. Azola. Hi, I am Amy Mooney, and I am primarily a caregiver to a child with severe ME. And I also am an occupational therapist, and I have walked in the hallways of many, many settings of the school, in rehab setting. So I've seen what traditional therapy does, and it does incredible work for a lot of diagnoses, a lot of illnesses that benefit from OT-PT and all of the allied health professionals. So I really do know the principles and the strategies that is offered in traditional settings. And as Dr. Friedman had mentioned, that a lot of the literature does not seem to address what people with ME are going through and benefit them for their care, for their quality of life improvements. And that's where I guess the past has done a lot of overlooking patients that have ME specifically. And I can, feel that that's going, if that traditional approach continues for people with long COVID, it will continue to miss a whole window of people. And Dr. Azola and I have talked about in the clinic, for people with PEM, the traditional approach seems to be missing a core piece, and they struggle with trying to provide the care that is specific for people with PEM. Long COVID, and as we've talked, long COVID and ME are not the same, but long COVID with PEM does reflect a lot of the characteristics of ME. And whether that's diagnosed or not, that is for a physician to determine. But for an occupational therapist or a physical therapist, what you get in front of you is what you are going to work and help. So the diagnosis at that point does not matter. I mean, it makes it a little bit more difficult. You have to do a little bit more research in what you're going to be encountering if there are a lot of comorbid conditions that are added on to the primary diagnoses. So just looking at traditional OT-PT guidelines, it does a lot to, the goals are set for improving or increasing activity performance. And then the goal is to restore health and functioning. And with improving and increasing activity, traditionally, it's to increase the strength, the range of motion, endurance, coping strategies, and also addressing illness beliefs. That's the traditional approach. And looking at this iceberg in my image here, that's the tip of the iceberg. And that is what you're going to see in the clinic. You're going to see presentations of somebody that looks weak, somebody that looks tired, and they're going to be struggling emotionally because it hurts, it's painful, and they've gone through a lot of trauma, and they're just trying to be here to get as much help as they can get. But what is out of view is PEM, and that is the crash. And PEM, when it's out of view from the clinician perspective, it's going to happen at home. It's going to happen in isolation, and it is not going to be addressed with any of the goals because it's not being seen. It's being self-reported. And a lot of times patients feel that they're going to be complainers. They're going to be seen as just trying to get attention, or, that it's more psychological based. And that is just not true. It's just not being seen. So that piece of it is, I think, needing to be addressed. But then also the patient is too unwell often to continue with the therapy schedule. And they end up dropping out of therapy or cutting appointments short. So that's another piece. And what happens is the therapist assumes that either the goals have been met, the patient is well, or the opposite, that the patient is unmotivated to continue care. And those, I think, are what is reflected in the literature reviews, that this model is not addressing PEM. And if we look at the next slide, these are what I see in my 7 years of being a caregiver. And it is to flip the iceberg. It is to look at PEM as the primary issue, looking at the crash and looking at that in isolation, and the rest will follow it. Strength, endurance, all of that will follow once you address PEM. And so my guideline is to flip the iceberg. It's managing symptoms, managing activity within the limitations of PEM, and that restoration of autonomy will lead to improved quality of life. And with those simple, but not so simple goals, that's where I think, in my view, people with ME, people with long COVID and PEM will benefit. So looking at the very, very quick outline is, prior to the session, is to address in a telehealth and a virtual call, is to identify PEM and look through screening tools, questionnaires, checklists. I think the DePaul questionnaire that Lenny Jason has put together, his team, is phenomenal. I think that needs to be used with most clinicians, and also using that if centers want to come up with their own, it needs to be at least used as a model. Developing PEM specific treatment plans, and those would be for symptom management. And we know that every single person with PEM, their symptoms are different. These are unique, and they also will change over time. So what somebody presents with one day will come back or speak with a clinician over telehealth with an OT or PT. They may have a different list. That number, the one that was maybe third on the list is now number one, and they alternate and switch around. So the symptoms are to be managed through pacing techniques, also for modifications and adaptations. That OTs are phenomenal working on ADLs, IADLs, and then also working in the environment that the patients or the people with ME are living. Where's their work? Where's their home? What's their school like? So looking at their roles. And then also patient and caregiver education is important. You need to have the whole team that helps the person manage their symptoms and provide their support involved in every step of the way. And how to do this is, and I know I'm running through a lot of these things because this is where chapters can be written on each one of those points. Utilizing tools and strategies within the limitations of PEM, Frames of reference. Frames of reference are what the OT community loves to use. This is our bread and butter of our profession. And we have, 25 some odd frames of reference that we use. And these are just an example. It's sensory integrative therapy, proprioception, and that's usually the proprioceptive is a neuro framework. And then the biomechanical and cognitive behavioral. And that's where I think if we look at the debunked PACE trial, they only seem to really want to focus on the biomechanical and the cognitive behavioral frame of reference. And we know that is not where people with ME and people with PEM are going to benefit. They have, yes, it's needed in the bigger picture, but looking at what their sensory component, what the neurological components are doing, what the symptoms are. Maybe they're not presenting as weakness, they're actually presenting as sensory impairments. The lights, the sounds, the touch is too stimulating for the nervous system. So using a biomedical approach is going to be putting the cart before the horse. They're not ready for it yet. So that's what the OT and the PT on the team needs to look for and adjust frames of reference and how to use the tools that they have in their toolbox. Guidelines and programs, and these are just examples. Heart rate monitoring, like Dr. Friedman had said, but we're also looking at the anaerobic threshold. Sometimes people are, if they are very severe, a tiny bit of stimulation is going to put them over the top. And it might not even be movement. It might even be having a bowel movement. It might have thoughts or emotions that are really going to be draining on their system. So looking at what their anaerobic threshold is, how high it is on the graph, but then also how narrow it is, because it might just need a tiny bit of stimulation and it throws it over the anaerobic threshold. Also looking at POTS programs, orthostatic intolerance programs, Ehlers-Danlos programs, and also craniocervical instability. Craniocervical instability has a history with autoimmune diseases. Rheumatoid arthritis has a history. If you do a literature search on CCI and rheumatoid arthritis, you will find that having cervical instability is not unusual. And just knowing that people with ME are now showing signs of cervical instability, that also needs to be looked at for people with long COVID. If they have some sort of POTS and autonomic dysfunction, there's a history there. So that needs to be looked at and researched as part of the process too. Flexible care, that's one-on-one sessions. This is not mass production of the care, and it needs to be done in a small setting. It can't be done in a big therapy center. It has to be done in smaller spaces. Telehealth, virtual care is imperative. And then also recording the program, putting it down on paper and also video recording, because patients need to be able to access those instructions on their own time when they can handle that information. And finally, consulting with your providers. Just because an OT and PT has great things to say, it needs to be communicated to the pediatrician and to all of the primary care and specialized care teams. This cannot be on only the caregiver's shoulders or the person with ME, because we don't have the bandwidth to have all of the complicated discussions. So it needs to be put down in form and then sent to all the different providers and work, and then school. And I think school can be a whole nother chapter in itself, because kids get ME, kids get long COVID, and kids really need help with their own specialized needs. Thank you.
So thank you so much, Ken, Alba, and Amy, for sharing your expertise and your thoughts with us. You've given us a lot of information to digest and think about. I'm sure there are many questions. Actually, there are many questions already down here, and I've been jotting my own as you've been speaking too. So it sounds like one of the major themes in the questions is how we find providers that understand all of this. Is there any kind of database for physical therapists that are, I guess, what you would call literate in ME/CFS? And, you know, or is there any other way we could go about finding these providers who understand or who are learning about this research?
Well, I guess I'll take that point. No, there's not a database of OTPT literate in PEM, and that needs to be done. There needs to be training, certification. There needs to be a way to network, and there is a Facebook group of us that are providers that Sally Reditsky and Melinda Maxwell and I are involved with, and we encourage providers to join our group, and it's physical therapists, occupational therapists, resources for treating ME/CFS, and we're a Facebook group. But that's not for how patients can find specific providers in their area. So I guess that is a great need. And I think the first part is by people being able to take some tools into providers and say, this is what I'm struggling with. Can you help me? Are you aware of PEM? Are you aware of some of the guidelines? Are you willing to do the work? Because maybe the best therapist and the best provider is not the one with 30 years experience. It's actually the new ones that have a lot of interest and are passionate about learning. And you can always train somebody to get the skills. It's just that, you know, the people that have probably been studying it the longest, they probably, unfortunately, have been using the traditional models. And I think we just need to kind of reinvent the wheel and try to figure out how to get more people on board with PEM and understanding, and then we'll be in really good shape. But until then, unfortunately, I'm sorry, no.
Yeah, thank you. Thank you so much. Alba and Ken, did you have any comments on that question?
I'm actively working with Amy to try to train some people because it's not, it's just not widespread knowledge at this point.
Yeah, thank you. I did just want to give a shout out to the Mass ME/CFS organization foundation. They do have a little link on their website that you can click on. I'll share it in the chat in just a bit. If you are a resident of Massachusetts or New England, you can contact them for, you know, provider specific information. If you're looking for a physical therapist who understands, and we're still working on building that database. If you live in another part of the country, or if you're in another country other than US, I would suggest just checking out your local support groups or your local organizations for ME/CFS and see what they have to say, because that seems to be where all this information and all these advocates are, right?
And also there's a really great group in the UK, Physios for ME. And so they do have a great resource network that, at least to get information for providers that are willing to work with the information. Mm-hmm. Look at Physios for ME page, because they do have some work to some worksheets and everything.
Yeah, great, thanks. And then I guess this kind of piggybacks on that previous question. Is there any way, are there any suggestions any of you have for responding to a provider that is recommending things like graded exercise therapy versus pacing, or even just, you know, self-advocacy in general, you know, because there seems to be a lot of gaslighting by providers towards patients with ME/CFS?
I can take a shot at that, having been through it. I think the first thing that one needs to do is to find a provider, and in finding a provider, I think the first step is an interview. What's important to you needs to be articulated to the provider, and ask him or her for his or her response to what is considered important to you. If the provider can't be sympathetic or supportive of the things that are important to you, then you need to keep on your search. Your search has not been successful at that point, and so therefore you need to search forward. There has to be a good fit between the provider and the patient. There has to be a rapport between them, and if that is not there, that relationship will not work. I think one of the concerns that have been raised in the medical community is that I'll go out on a limb and say the predominant healthcare model provides 15 minutes allocated to the provider per patient, and certainly for ME/CFS patients, that is an insufficient amount of time. So one of the things that needs to be looked for is a provider that is willing to go beyond 15 minutes per session to be with you in order for you to make progress. And if that provider isn't willing to, then again, you just need to go on. It's very difficult. It may take years for you to find a provider.
And I just want to share a little bit about the perspective of a provider in seeing this patients. It's complex. I mean, never as complex for us as it is to be the actual patient, right? The suffering, it's incredible, but for physicians, it's not easy. I have a group of physiatrists that a lot of them have decided not to take care of the clinic anymore, or see patients in the clinic anymore because it's so tough. We want to sign up to do medicine to make people get better, and a lot of medications, like patients are very sensitive to medications. Dosing has to be done very meticulously. Constant titration, frequent visits. It's not simple as a provider, but I think that, for example, telling somebody to put earplugs because sound sensitivity was horrible was one of the biggest interventions that I've done on a patient. And there's value to that. So I think that it's important as a physician to just allow a safe space for patients to tell you what they're experiencing and what their body's telling them. So I think if you find a physician that allows you to feel safe enough to express what your body's telling you, I think that goes a long way for sure.
And I have one more point. Because there are so many comorbid conditions that people are experiencing, sometimes finding a therapist who has experience with PACTs or Ehlers-Danlos can also widen the search a little bit with, by going to a Facebook group or looking for somebody that has had a good experience with a therapist. By getting a recommendation through other groups is also a way to find willing therapists. And unfortunately, this is what's so brutal, is most of them are private pay. So that's a whole other layer of the onion that it's costly.
Yeah, it's unfortunate. I wish all providers could be like the three of you. I'm sitting here just, we only had more of you guys in the field. Thank you so much for those answers. Those are great. It is now past 5:15. So if anyone needs to sign off, we completely understand. And this is going to be recorded and posted on the Mass ME/CFS YouTube channel as soon as we can, as well as the slides will also be posted on our at massmecfs.org website. I just wanted to ask a couple more questions, if that's okay with you all. There were a couple of questions about the equivalent for the device for measuring cognitive exertion. I know you talked a lot about medical devices and your heart rate monitors and stuff like that, but many patients with ME/CFS have this cognitive fatigue too. Is there anything out there that helps actually measure that?
No.
Other than maybe, I mean, I guess it's not a standardized measure, but doing some checklists on how people are handling some of the ADLs and multiple steps. You can do some in the IADL, more executive functioning levels, looking at how they can work through a problem or do a task from start to finish. So OTs also are well versed in activity analysis. So watching a person actually perform a task or work through a task is a way to maybe look at at what level they start losing their focus. Yeah.
I wanted to give a shout out to the speech language pathologists, which are the one therapy team that we haven't talked about much. And we definitely, in our clinic, we have speech language pathologists that work in cognitive therapy. Again, you have to be really mindful of the PEM on those patients, but they can be helpful in kind of giving tasks and seeing the response to those tasks and helping you find what is that threshold, if it's 1 hour, 2 hours, and then taking a break. A lot of people find that helpful. Like Dr. Friedman was commenting, like breaking up the sessions of computer work, for example, if that's what they do for their job, into smaller pieces and having breaks in between. So sometimes the speech language pathologists can be helpful in finding compensatory strategies as well to compensate for memory issues, for sequencing issues that they may have. So yeah, that's another group of therapists.
The piece, though, I want to point out is often with people with ME and long COVID with PEM, these are not necessarily permanent. I mean, there are permanent brain damage issues, cognitive impairments, but it is most often a temporary situation. And by actually reducing PEM and reducing symptoms and doing different strategies and compensations, it provides more cognitive bandwidth for harder tasks or things that are going to be more meaningful. And the focus that somebody wants to be doing a very important task at a certain point in the day, by teaching them compensation strategies earlier to be able to manage that cognitive fog piece. So some of it can be for people that have had long time ME, but it's not necessarily treated as like somebody that has had a stroke, and there is, there's definitely some neurological impairments from the cognitive levels.
Yeah, that makes a lot of sense. Thank you so much. And then, Amy, there were a couple of questions for you about how do you move towards finding the anaerobic threshold? There were a couple comments, just people wanting more information on that.
Go to Work Well and they have a lot of information on their website, workwell.com, I believe. It's a group of exercise physiologists and PT. So that information is at their website, but it's also looking at kind of where, if you don't have the resources to go and really get the certain tests done, by finding out and doing more journaling on where you feel you are best able to be productive and where your work is managed before you start feeling the effects of PEM. So it's kind of like a self checklist, and staying under that window and start monitoring your pacing, because as soon as you feel like, okay, it's been 10 minutes, I've been upright for 10 minutes, I can feel my brain fog's setting in and I'm getting maybe nauseous, I've got sore limbs, that is beyond. You need to have stopped at 8 minutes. And so the next time you have an activity, set the alarm, literally like turn on your alarm that at 8 minutes, you need to do a self-check. So just doing a lot of self-check strategies is a way of managing without having the clinical resources to really pinpoint when it is that you're actually, your body is physically changing into lactic acid results. So doing, just doing a lot of self-monitoring is kind of the low-tech way to do it. Also using some heart rate, just buying, a Fitbit and watching how your body is responding to certain activities.
This is actually a personal question. Do you know if insurance companies cover like Fitbits now, or is that something that we still have to go out and buy on our own if there's a certain like diagnosis along with it?
I haven't heard of anybody getting it paid for, but I'm not sure.
Popped in my mind because I was like, I want one for myself, but if patients are if that would greatly help them, it would make sense. But yeah, a lot of things need.
Can I just add a little bit to that from the physiological, point of view? Going into your anaerobic threshold obviously has to do with oxygen consumption, and your body monitors oxygen consumption. And one of the things that happens when your oxygen consumption gets lower, obviously your blood oxygen becomes lower, and the body responds by increasing heart rate. In other words, trying to get more oxygen to the tissue by increasing the flow of blood, because in the blood is where the oxygen is that gets into the tissue. So by monitoring heart rate or a change in heart rate, particularly an increase in heart rate, you get an idea as to when you are consuming more oxygen. And yes, it's true, a Fitbit would be ideal, but I think a Fitbit is kind of pricey. You can also buy something called a pulse oximeter, which you put on your finger. It has maybe 1 or 2 small batteries in it, and you clip it on your finger. It will tell you your oxygen concentration, but they also tell you your heart rate. So that, and I think they're about $30, maybe $40 last time I looked. So for $30 or $40, you can buy a pulse oximeter and focus on the heart rate monitoring aspect of it as you do something, and try and correlate the increase in heart rate that you see with the onset of the anaerobic threshold. Just try to stay below a certain heart rate to maintain your ability to continue work.
Great. Thank you. I know we hear about pulse oximeters a lot with talking about COVID and acute phase of COVID. There were a couple of questions for you, Ken, about whether or not or how to distinguish maybe ME CFS onset after a concussion or other physical trauma with no known pathogen exposure, and just other maybe illnesses such as like breast plant illness causing ME CFS, and then comments coming from COVID long haulers on that connection with ME CFS. Do you have any more comments in relation to what you said about PAPIS, finding the specific causes, or whether or not that's helpful, or do we just kind of accept that we're in this umbrella of ME CFS?
Well, at this point, the actual cause or causes are unknown. There are obviously some candidates that are higher ranked than others. Mm-hmm. Most likely, I think immunology is involved. I think that for both viral and bacterial infections, there is talk about the immune system becoming overworked and therefore no longer being able to provide the surveillance or suppression of the viral illnesses that once were. I think that for the majority of ME/CFS cases and for long haul COVID, the virus remains in tissues. For most of us, it remains contained within the tissue, but under certain circumstances, when the immune system is no longer adequately active, then those viruses can emerge from the tissues and start circulating throughout the body. And then you have an infection again. And I think for a lot of ME/CFS patients, their condition can be correlated with the viral load that's found in the blood. They feel better when the viral load is low in the blood. When they feel worse and they go to their physician and viral titers are assessed, they find out that, yes, their viral titers are back up, and they try and knock them back down with antivirals again. I think that the example that has existed is probably chickenpox and shingles. At one time, it was thought that chickenpox was a childhood disease and you just get over it and it's gone. And it turns out that no, the virus does remain and can express itself later in life when your immune system starts to decline, such as in people like me. And you can get a reemergence of the chickenpox virus, and it takes the form of shingles going along essentially the pathway of nerves and expressing itself on the surface of the body, being particularly painful. And there are other examples like that. So I think we need to recognize that it is a common, if you pardon my language, physiological phenomenon at this point. And once we recognize that and attempt to deal with it, we will have better tools for treating a lot of other people.
Okay, great. So we just have one last question, and that is if any of you can just give an overall explanation for the difference between physiologists versus physical therapy versus osteopathy and how they all relate or coordinate.
I can try. I speak to physiatrists or physicians that studied medicine and then did a 4-year training on physical medicine and rehabilitation. And like I explained a little bit on my slides, we learn about different impairments in different conditions, neurological, infectious, any type of condition, autoimmune. Anyway, we help patients cope with impairments and improve their quality of life. And then we work very closely together with physical therapists. Physical therapists, like it was mentioned earlier, are trained on helping the patients gain mobility, I would say, I think in a very simplified way. So they focus more on mobility and activity. The OTs, like it was mentioned earlier, are another group that works in activities of daily living, or basically showering, bathing, dressing, brushing teeth, how to make the patient more independent within the context of their impairments to be able to do those things. So, and then speech, language pathologists, they address swallowing difficulty, they address cognitive symptoms, and speech impairments. Now the physiologist, I'll let Dr. Friedman explain.
Yeah. Physiology is essentially the study of body systems or body organs, so that let me back up and say that there are two kinds of medical schools. There's allopathic and osteopathic. An allopathic medical school, where I taught for 34 years, our approach is to build knowledge based upon the organ systems, so that we start with the cell and cells and how cells work, and we build them into tissues such as the nervous system, the digestive system, the nervous system, etc. So the physiologist studies at the cellular or organ level and tries to learn how those particular pieces work. And then in medical school, after allopathic medical school, after you study those organ systems, then you try to combine them or show the control mechanisms that put those organ systems together so that we can function as a total organism or a whole body. I have not taught in osteopathic medical schools, even though I now have a title in one. But the approach of the osteopathic schools is to treat the body more as a whole. So I suspect that in their coursework, there would be less emphasis on the organ or organ systems, but rather on the entire body. So that rather than focus on an abnormality in a particular organ, they would work from the body as a whole down to pinpointing the abnormality. But in pinpointing the abnormality, their approach would be the consequences of that abnormality on the entire body. Whereas in the allopathic school, it would be the abnormality in the organ system and, oh, what consequences will that have on the entire body?
Great.
Can I just say one quick thing about OT and PT? Often they come together tag teamed for a referral, OT, PT, do assessment and treat. And OT is from a public health. Our background is public health, and we have a view of bringing the person back to the meaningful tasks after injury, illness, disability has occurred. And we use multiple frames of references that will look at the nervous system and all of the pieces all of the body pieces of the body of the individual. PTs come from more of a medical model background. And so they are looking at the nuts and the bolts, how the body is working and what the physics and the structures of the body, the muscles are doing to the bone. And that piece of it, I mean, I think we really work well together, and often we'll have goals that resemble each other, but OTs will come at it from a kind of a roundabout way and looking at how the nervous system is working, and is the light too bright, is the sound too stimulating, so those are the pieces that we are looking at that make the activity difficult. But a person that has a PT view is going to come and look at it as a biomechanical, and that's why PTs really do a good job looking at heart rate monitoring and teaching, kind of because it's very structured. But there's no reason why an OT cannot become knowledgeable of that stuff too. So I think if you are looking for an OT or PT, don't be scared of one or the other and say it has to be this particular one. I think that if you find somebody and say, you know what, but it's a PT and I'm really having a lot of sensory issues, they can still help, but OTs probably have come to that more naturally, just in their background and their training.
Great explanation, thanks. And thank you all three of you for such wonderful presentations, for your advocacy and for helping this population and moving the ball forward. So I think we're finally come to the end, but like I said before, all speakers have agreed to address unanswered questions, and we'll post those as soon as we can. And once again, this recording of this session will be posted on the Mass ME CFS YouTube channel, in addition to the slides being posted on the massmecfs.org website. Thank you all so much for coming. Our next Sunday conversation is February 20th, every third Sunday of the month at 4 p.m. Eastern time. The topic is on applying for Social Security disability And the presenters are two Mass ME board members with expertise in the subject. Ken Casanova, who leads the patient services team and has guided many, many patients through this process. And Rob Beluso, a board member and disability attorney. The presentation will focus on ME CFS applications, but will also review the Social Security rulings for fibromyalgia and long COVID. Finally, if you have found this program worthwhile, there are a few ways you can help. You may make a donation of any size to help support this series. You can donate online or at massmecfs.org/donate. On the same page, you can sign up for our newsletter. And if you donate $25 or more and check the become a member option, that will establish or renew your membership, and you'll be invited to our members only programs. If you have ideas for future programs or speakers, or if you would like to join the Sunday Conversations team, please email events@massmecfs.org. Sunday Conversations is not intended to be a series of research presentations, but rather programs that will provide a variety of practical information that patients can use. So thank you so much again, and we wish you the best in the coming months.